Our next speaker is Dr. Lipi Chakrabarty. He is HOD at CCM Government Medical College, Durg. Also runs an independent eye care center, Lipi Ka Netradham at Chhattisgarh. Been glaucoma consultant and done glaucoma fellowship from Arvind Eye Hospital and PG Institute, Madurai. Dr. Lipi.
Yeah, good afternoon all. So it's already 12. I will try to rush through my presentation. And the topic is trabeculectomy procedure and precautions. No financial disclosures. Principles of trabeculectomy surgery. This was introduced by Dr. Kans, as most of us know, in 1968. What this surgery does is it channels aqueous flow into episcleral venous network through a patent sclerostomy under a partial thickness scleral flap. There are sutures fixed or releasable to control aqueous flow, antimetabolites like MMC or 5-FU to reduce scarring, and there are some miscellaneous steps to this trabeculectomy surgery. Let's go through the steps fast. So step 1 is taking the bridle suture. The superior rectus suture instead of this corneal traction suture can be taken. It is preferred also by many glaucomatologists. Conjunctival dissection. There should be a complete dissection. Fibrous tissue should be nicely excised. Posteriorly also we need to go so that the posterior conjunctiva, unlike in SICS, posterior conjunctiva here is excised thoroughly. Then step 3 is a gentle cautery. So not much to it. This is a gentle cautery being done. Scleral flap measurement. The measurement taken is around 4 by 4 or 3.5 by 3.5. It depends upon the surgeon's ease and experience, whether we are planning a combined or a trab alone. Next we have, after measuring the scleral flap, we need to take the groove. This is done with 11 number blade or any blade the surgeon is comfortable with, rectangle or triangular flap. Triangular flap, the tip is to be raised uniformly, nicely. A clean cut raising of the tip of the triangle is to be done. MMC application in the form of MMC soaked sponges, 0.02 or 0.04 milligram per milliliter concentration. It varies as per the case. Injection MMC can also be done. That will be shown in a successive video. Then we are lifting the scleral flap. So this has to be again a very clean lifting with the same 11 number blade. And as we approach the limbus, this 11 number blade can be replaced with a scleral crescent. So this is what I do. This I have learned at Coimbatore, Arvind Eye Hospital, Coimbatore. These are Dr. Satyan sir's video. Actually, we have learned our trabeculectomy seeing his videos, so I am maintaining that. This is a side port. Side port it has to be taken in combined surgery, like this is a combined surgery we are planning, and in trab alone also we need to have a side port so that at the end of trab we can form the AC nicely and we can see the aqueous outflow that is there to the bleb or not. These are essentially the cataract steps. This is hydrodissection and phacoing of the cataract will be done. Then this is PC wash with IOL implantation. Yeah, so this is that phaco probe is going, it's doing all the phacoing part. The main trab steps which we need to go through are trabeculectomy, PBI, peripheral basal iridectomy, and viscoelastic wash. So this is how the punching is done. It can be done with the Kelly's Descemet punch, or sometimes Vanna scissor is used. The Kelly's Descemet punch size is 50 micron or it is 1 millimeter. When the ostia is punched, then we should have that in mind that on either side of the ostia about 0.5 millimeter gap is left. So you can see that the ostia is here and 0.5 millimeter gap on either side of the flap is left. This is the iridectomy done, and this is the releasable suture. I do it this way. This is a step 1, cornea to cornea. Step 2 is from cornea to the scleral flap, and step 3 will be from the flap to the sclera. So these are the 3 steps, and after doing this we need to tie the 4 knots, circle it 4 times. So this is 1, 2, 3 and then 4. Yeah, and we do not need to lock it here, we just need to leave it as such. Then step 3 will be conjunctival closure. This can be done in a continuous way or interrupted. When we take, then we need to take tenon to the conjunctiva first, and then conjunctiva to conjunctiva can be done. 2 or 3 bites can be taken. And when we oppose this conjunctiva, it should fall on the cornea. So it should sit there as a ridge. It should not be like in SICS that we are not touching the cornea when we are opposing the conjunctival flap. But in this trabeculectomy, you can see that sort of ridge which is forming. It is sitting on the cornea. So this ridge, this belt that should be there, this takes care of the trabeculectomy, the posterior aqueous outflow. This is an easy step. The last step, AC reformation, checking for leak. Then SC antibiotics and steroids, this is optional. This is trimming of that releasable suture. It is cut flush with the cornea. There are other methods of taking releasable sutures. This was that MMC which I was mentioning, subcutaneous injection of MMC that can be done about 7 to 8 millimeter from limbus. A Vexel sponge is used to distribute this MMC and also to prevent mitomycin C from going towards the limbus. Deep scleral incision that can sometimes happen. So there are some oops moments in trabeculectomy. In this we have a deep scleral incision being taken here. The incision should be around a half of a sclera. So here we can see that it's very deep and the flap is being raised. Along with that, there is a choroid show. This should not be done. Ideally, this should be sutured, and different site trabeculectomy can be planned. Then this is bleed during aridectomy, common in those who are into antiplatelets and other similar drugs. So we need to take care of that BTP, TCT and all. This all creates a mess. We need to wash this with Simcoe and then put air bubble. Positive Seidels test, this can be seen if the conjunctival closure is not proper, if the flap is not properly taken. So this all can happen. There's a big leak. The dye is flowing, so we need to put a BCL or suture. Opposite to this leak, we have cases of bleb failure. There are varied causes to bleb failure and fibrosis. In bleb failure, which is more common than the leaking bleb, we need to recognize failure, identify the cause, and then treat the IOP, rising IOP, and try to restore the bleb function. These are the varied types of bleb we can get after trabeculectomy. Because fibrosing bleb or failure of bleb is more common, digital massage is something which our young postgraduates and comprehensive ophthalmologists should know of. Patients can also do this. Releasable suture, again, this has to be in the armamentarium of comprehensive ophthalmologists also when they are doing a trap. So the apical releasable suture is released here. The bleb was almost flat and there is no digital massage being done. With a single blink of the eye only, the bleb has started forming. It is rising nicely and it is occupying almost half of the eye. So this is the beauty of releasable suture. So at the end, I would like to conclude that what seems to be what seems to be an iceberg, it is actually many a time only the tip of the iceberg. So trabeculectomy as such is a simple surgery, but there are many other issues involved in it which can be dealt with experience. Thank you AIOC for giving me this opportunity, and thank you our Chief Instructor Dr. Deepak Mishra for having me in the